Yeah, so welcome everybody to the Global Medical Physics Education Lecture Series. We're very lucky to have Dr. Aram Rostami here. So he is from the Hamad Medical Corporation in Doha, Qatar. He's a good friend of mine, and I heard him give this lecture in Italy last month, and it was an excellent lecture. So we're gonna have him talk about quantitative radiobiology for treatment planning. So he'll give the talk, and then if you have any questions, put them in the chat, or then when he's finished giving his talk, we'll have time for a Q&A session. So I'll turn it over to Aram and take it away, Aram.
Hello, everyone. First of all, I would like to thank Joe for inviting me to deliver this topic. Just I need to say that this is the second time that I deliver this topic. First time I delivered this one in the ICTP 2025. It might, if you search it, you can find it in the ICTP website. With a few changes, I will repeat it today again. So the topic that I'm going to talk about that today is a quantitative radiobiology for the treatment planning. It can be quite new for everyone. There is no conflict of interest to declare. I will start my presentation with a short introduction about the topic. In continue, I will talk about limitation of physical quantity-based treatment planning. And after that, we talk about after the limitation of the quantity-based treatment planning, we talk about that why we need biological quantity. On top of that, in continue, we'll talk about generalized equivalent uniform dose, normal tissue complication probability, and tumor control probability as a biological quantity for the plan evaluation and even for plan optimization. And I will end up with the summary and key point of my presentation. Oh, okay. As you know, one of the most important step in treatment planning radiation therapy is the plan evaluation. In our clinic, in our routine clinic, usually we use physical quantity for a plan evaluation. The parameters that we use in our routine clinic are, I summarize some of them here. Like homogeneity index, which is talking about uniformity of dose inside the target, conformity index, which is talking about coincidence of the prescribed dose with the target volume, target coverage, which is talk about the volume of target that is covering by prescribed dose. Conformity number is very close to the concept that introduced by PADIX. Critical organ scoring index is a comprehensive index for the plan evaluation containing target coverage, normal tissue sparing, and dose volume histogram, which is one of the most powerful tools that we use for the plan evaluation, for target coverage, and those constraints of the OERs. And we have many references like RTOG, Quantec, Timmerman, EMAMI, and many of them are available in literature that we usually refer to. We go to them and we check those constraints of OERs to see to evaluate the quality of our plan. This is our routine in clinic, but what is the limitation of this physical quantity that we use during the treatment planning, especially in the plan evaluation? I summarize four main limitations of the physical quantities. First of all, I like to refer you to the AAPM task group number 166, which is a very comprehensive and nice document prepared by APM focusing on the biological-based treatment planning. You can find a lot of information, especially for researcher and the student. And by reading this document, you can get a lot of idea about the biological-based treatment planning. First limitation of physical quantity, as I mentioned, there is no direct link between physical quantities and biological response. A physical quantity just describes the dose distribution without giving you any idea about biological outcome. I borrow this nice sentence from TG 166 that Dose uniformity doesn't guarantee the tumor control, and DVH constraint doesn't guarantee the safety of the OERs. Why? Because I told you that physical quantity is only talking about the dose distribution. You cannot get any idea about outcome of the treatment. Second limitation of the physical quantities is that you cannot differentiate equally good plans. If you have exactly two similar plans, it might, you see that these two plans are based on the physical quantity are very similar, but the biological response and biological outcome can be completely different. In the next slide, I will talk about this limitation more in the next slide, actually. Third, the limitation of physical quantity is a lack of individualized prediction. All of these protocols and references that I mentioned earlier in the previous slide, like Timmerman, like RTOG, like Quantec, MME, and so on, all are based on average population data. But we know sometimes we have a patient, young patient, old patient, different gender, man, woman, different race, that they can have different sensitivity or different resistance to radiation. We cannot apply the same protocol for this scattered population. This is another limitation of the physical quantity. And the fourth one that I like to discuss is that there is no integration of dose per fraction or BED for the physical quantity. You can have, for example, two plans with the same total dose, but let's imagine you have the plan with 40 gray in 5 fraction, 40 gray, and another prescription in 40 gray in 8 fraction versus 40 gray in 5 fraction. Both has same total dose, but as you know, the biological effect will be completely different, which physical quantity cannot clear such a difference for you, and you need some more quantity to clarify or to clear these differences more for you. I have one clinical example here for you. The scenario is that we have two SBRT lung plan A and plan versus plan B. Plan A, PTV is 95, OER is within the Quantec, homogeneity index is 1.1, and conformity index is 0.85. Plan B has same DVH, but in terms of the biological modeling, you can see the tumor control probability is 80% versus 91% for 85% for plan A versus 91% for the plan B. And normal tissue complication for plan A is 12% versus 6% for plan B. You can, if somebody ask me how two exactly similar, this is just example, similar plan can have different biological response or biological outcome. Just simple example is like, say, both plan have, for example, 105 max dose or 110 max dose. But this max dose, by using the physical quantity, you cannot specify where this max dose is happening. It might in plan B happen in the hypoxic area of the tumor, which increase the tumor control probability, versus plan E, that same max dose, it has same max dose, but in the different location inside the tumor, like in the normoxic area. These two small difference can lead significant difference in tumor control probability. In conclusion of this scenario, we can say the DVH in this scenario suggests that both plans are equivalent, but biological modeling show the plan B is clinically superior. So, to overcome this physical quantity limitation, we need to introduce biological modeling and biological quantities. Here, I summarize the differences or comparison between physical quantity and biological quantity. Basis for the physical quantity is the geometric and dosimetric versus biological quantity, which are tissue and tumor response. Example of the physical quantity are like conformity index, homogeneity index, deviation, tumor control index, tumor coverage index, sorry, tumor coverage index, conformity number for the physical quantity versus tumor control probability, normal tissue complication probability, equivalent uniform dose, the biological effective dose for biological quantity. Personalization is limited for the physical quantity. As we discussed, all of the data for the physical quantity are population-based. There is no personalization, but biological quantity can be patient-specific. By using the physical quantity, there is no outcome prediction versus biological quantity that you can have actually the outcome prediction. What is the AAPM TG166 recommendation in this term? As I mentioned, is one of the valid reference in this area or in this topic. TG166 recommendation is still you use physical quantity as a baseline or as a routine. That's what we do usually in routine clinic. In top of that, is recommended that you integrate the biological index for the clinical decision. Now, in continue, we will talk more about the biological index and how we can calculate, how we can reach, and how we can use it in routine clinic. So when we are talking about biological-based treatment planning, it's important to know that we are talking about using biological plan for optimization and plan evaluation, or either one of these. For example, for the inverse planning technique, we can use biological-based treatment planning for optimization and plan evaluation. But for forward planning, we can use it only for plan evaluation. We'll talk about this more in next slides. When we are talking about the biological-based treatment planning, usually there are three main models or quantity that we need to know, and we can use it for biological-based treatment planning: equivalent uniform dose, tumor control probability, and normal tissue complication probability. You will go through these parameters one by one. So generalized equivalent uniform dose is one of the biological quantity which is nowadays, I can tell you can find it in all famous and popular TPS like Eclipse, Monaco, and Ray Station. You can find GEUD in all of them, and you can use it for plan optimization and plan evaluation. But we need to know what is the GEUD and how the GEUD work. First of all, equivalent uniform dose introduced in 1997 by Nimerco. Equivalent uniform dose is a dose that is uniformly delivered to structure. That structure can be OER and PTV. That would produce the same biological effect as the actual non-uniform dose distribution. We'll talk about that with one example that can make this concept more clear for everyone. In IMRT, VMAT, SPRT, and SRS, we have highly modulated dose distribution. For example, in one part of the tumor, you can have hot spot. In one part of the OER, you can have unusual high dose. By using the physical quantity like D95, D20%, or V20 gray, or the average dose, homogeneity index, conformity index, you cannot describe such a differences and biological outcomes. How we can overcome to this limitation? By using the generalized equivalent uniform dose. In this figure, you can see the dose differential deviation for left parotid in head and neck case for two plans. The blue one presenting plan A and red one presenting the plan B. As a user, as a physicist, basically just by looking at this to DVH, you cannot get any idea about how which one has hurting making more complication in the parotid, but because you have completely different DVH. One of them has higher volume in high dose, lower volume in low doses, and opposite. But by calculating the generalized equivalent uniform dose, you can differentiate these two easily in only by single meaningful number. Here you can see the GEUD for the plan A is 48 gray and GEUD for the plan B is 42 gray. That you can reach to this point, the risk of the complication for the plan A is higher than plan B. Again, GUD is or equivalent uniform dose is the dose if you uniformly deliver to the structure would produce the same biological effect if you if you deliver very high dose to some part of the to one part of the structure that can be healthy tissue or the PTV. How we can calculate the GUD? This is a formula that based on that, we can calculate the GEUD. N is presenting number of the voxel. V presenting a fractional volume receiving the dose, specific dose, and DI is a dose to voxel or beam, and alpha is a parameter that is tissue specific and presenting the volume effect parameters. Selecting the proper number for alpha is very important. If you go with a minus value for alpha, basically you approach a minimum dose. If you go with a positive value, you're approaching the max dose and average dose. How? For example, if you want to select the proper value for the two more, that can be GTV or PTV, you need to approach the minimum dose that's received by the PTV. Usually you push the minimum dose by PTV to higher value as much as possible. That's why you need minus. Usually minus 10 is sensitive to cold spot. You can use it between -1 to -20 as a proper value for the target. But if you want to use the GEUD during the optimization, plan optimization for the healthy tissue or OERs, you need to use positive value. For serial organs like spinal cord, we use usually the between 10 to 20, and for the parallel organ that we approaching the mean dose or average dose, we should use the value below 10. There is one reference, ICRU51, that you can go and find the proper value or recommended value for each structure. But I recommend you to go with a vendor suggestion. For example, in Eclipse, since I'm the Eclipse user, if there is a document that you can find the proper value based on the structure that you can apply for during the optimization by using GEUD. Here you can see a screenshot of the optimization window for the Eclipse treatment planning system. In Eclipse, you can use upper GUD, lower GUD, target GUD, and here, for example, I have the PTV and I use -1. As I mentioned, if you use the GUD, you want to use the GUD for the target, you need to use a minus value versus the healthy tissue that you should use positive value. As I mentioned, GEUD already work within the current TPS like Eclipse, RayStation, and Monaco. And you can use the GUD alongside the physical dose-based function during treatment planning for plan optimization and also plan evaluation. If you want to use the GUD for the healthy tissue, if you want for the serial organ, you need to decrease the max dose. In the same time that you are decreasing the max dose, you need to accept increment in the mean dose or average dose of the organ is like a penalty that you should accept it. And for parallel dose, in the same time that you are trying to reduce the average dose, you need to accept a higher max dose to that parallel organ. Sorry. So another two biological parameters that or index that you can use during the biological-based treatment planning are TCP and NTCP, tumor control probability, and normal tissue complication probability. TCP actually is about likelihood of the tumor eradication, and NTCP are focusing or describing the risk of the normal tissue toxicity. TCP and NTCP used to balance the tumor control versus OER toxicity. And so there are a lot of model for tumor control probability to calculating tumor control probability, which the differences in between this model are based on the biological outcome. For example, one of the famous model, TCP model, which is available in the literature, is Poisson TCP model, which is a model based on the cholinergic survival. To calculate the TCP based on this model, the formula for calculation the TCP in this model is equal to e power minus n multiplied by survival fraction. And survival fraction is equal to e power minus alpha. Alpha is a coefficient describing the linear part of the survival curve, multiplied by d. Dose is the received dose. D is representing the received dose, plus beta is a coefficient that presenting the quadric part of survival curve, and multiplied by d again power 2. By using this formula and have proper parameters, you can calculate easily the tumor control probability for a specific tissue and dose prescription. Also, we have many different NTCP model. One of the main and famous one is a Lehman-Kutcher-Berman or LKB model. Another one is a relative seriality model. Here you can see the formula of NTCP model based on LKB model. In the LKB model, NTCP is a psi t. T is a parameter that you can calculate it by using this formula. D effective is effective dose based on the DVH. TD50 is a dose causing the 50% complication rate. M is the slope of the dose response curve that you can get it from the cell survival curve. And psi, as I mentioned, is a standard normal cumulative distribution function. Here I provide one clinical example for the TCP calculation for one nasopharynx tumor by using by the prescription 70 gray in the 70 gray in 35 fraction. If we assume that PTU volume is 120 cc, cell density 10 power 7, number of the cells 1.1 multiplied by time 10 power 9, alpha value 0.3, beta value 0.3. Equivalent uniform dose you can calculate it by using the DVH data, which is 70 gray in this case, by using the formula that I introduced in previous slide. You can calculate the survival fraction for this specific EUD. At the end, you can calculate the tumor control probability, which is in this case for this specific volume of tumor and this dose prescription, tumor control probability is 100%. In same case, if you want to calculate NTCP for spinal cord, you can use LKB model, sorry, by using the formula that again I introduced in previous slide and put in the proper value in top of that. you can see the risk of the myelopathy for the spinal cord is 0.14% by delivering 35 fraction to the spinal cord. You can see even among the 1,000%, there is a risk for two people to have normal spinal cord myelopathy complication. Even 35 is a dose that usually we always feel that is safe for patient, and sometimes we accept up to 450, but you can see in this case 35.48 gray has for significant risk. Current clinical usage, if you want to see which TPS are supporting this biological quantity, as I mentioned, GEUD is supported by many of the TPS like Eclipse, RayStation, and Monaco. TCP and NTCP is not supported by Eclipse for plan optimization, but for plan evaluation, you can use it, TCP and NTCP inside the Eclipse. For RayStation, TCP and NTCP are available for plan optimization and plan evaluation. Monaco as well. Monaco is doing very great job in this in terms of the biological base optimization, is one of the strongest that you can find, and we can say generally biological treatment based planning is slowly growing inside the treatment planning system. Sometimes maybe you look for open sources for NTCP and TCP calculation. One of them very powerful open source software which is available in literature in the network is radiobiology. Is open access, free. You can just Google it and go in the website and find the latest version, download it, and is very user friendly and you can use it easily. Radiobiology is scriptable and open source software, ideal for automated model evaluation and sensitivity studies. Required input data to use this software is DVH data. Usually we need a differential DVH, alpha beta value, TD50M, which is slope of the dose response curve, dose grid, and fractionation. What you can calculate by using this software is TCP, NTCP, EUD, GEUD, and BED. One of the most powerful software that is similar to the treatment planning is which is MATLAB based and is MAD-RT. MAD-RT is the open source software, MATLAB based, that developed by German Cancer Research Center. You can do even the planning in this software. You can do the optimization, plan evaluation by importing the data like DICOM-RT structures, voxel data, and beam parameter. At the end, you can create the plan by using biological parameters, and at the end you can also have the plan evaluation by using the TCP, NTCP, and GEUD. I just had a quick look and quick search. I found more than 40 papers in the last 3 years cited this software and is validated by more than 40 papers in the last 3 years. It's very strong and reliable software, which is open source software. Another open source software for NTCP and TCP calculation is TCP NTCP calculation, which is MATLAB based. Again, required data for using this software is the DVH means, dose per fraction, alpha beta ratio, TD50, and slope of the dose response curve. You can get it as an output. You can get TCP, NTCP, EUD, and BED from this software. There are another software which you can use it, open source software for NTCP and TCP calculations, SEER, MATLAB-based, numerical EUD-based calculator is MATLAB-based, DVH toolkit is Python-based. You can also find them as open source in the network. And if you ask me why still TCP and NTCP are not widely used in the clinic, I can give you five main reasons for that. First is lack of reliable radiobiological parameters. If you, for example, if you want to look for alpha beta for a specific tumor or a specific structure, you can find a lot of data, scattered data. You can, and sometimes you will confuse which one is the correct one. Since you don't have a comprehensive document that validate the alpha beta ratio and give you this confidence that you can this value, you don't have such confidence to rely on the alpha beta value and other biological parameter to calculate the TCP and NTCP. Another limitation is large interpatient variability. As I mentioned, radiosensitivity differ significantly between the patient, and there is no clear way to differentiate these differences between the patient. Limited validation is another limitation of this. Using the TCP and NTCP in the clinic. Most of published models are based on the retrospective study, and you cannot find comprehensive prospective clinical trial to prove that you can rely 100% TCP and NTCP models. Another limitation is a regulatory and practice barrier. If you go through the AAPM, ISTRO, and ICRU guideline, they are still recommending the DVH-based constraint. Many OER dose constraints are standardized as a Dmax, average dose, and DVH-based, not NTCP threshold. And workflow and time constraint. Biological optimization is more computationally intensive rather than using only the DVH parameter for optimization. At the end, I can tell you, I can summarize my talk in this slide, why the biological modeling matter in radiotherapy, physical dose metrics like DVH, D50, D95, average, D mean or D average cannot predict the biological outcome reliably. Plan is a similar DVH, as I gave you an example, can have a different TCP and NTCP, uses GEUD, TCP, and NTCP to provide clinical meaningful endpoint for the plan comparison is one of the another limitation. What is the advantage of the biological model using the GED, for example, convert complex DVH into a single biological relevant value? TCP predict the likelihood of tumor control, and NTCP estimate the probability of the normal tissue complication. Many of them integrated in the modern TPS like Eclipse, RayStation, and Monaco. What was the limitation of this biological model? Was one of them was lack of the patient-specific radiobiologic parameter like alpha beta or TD50, higher interpatient variability in radiosensitivity, limited clinical validation, and last one is biological optimization is computationally intensive and need more time. You need to spend more time during the plan optimization and even for plan evaluation. And if anybody has any question, you can reach me by using this email address. Yes, Joe.